Okay, so one of the more challenging lesions that we have to deal with that causes stenosis and causes resistance to outflow of the cerebrospinal venous circulation is the hypoplastic internal jugular vein. These veins are quite challenging. They are not very well amenable to uh, angioplasty, and they are fraught with risks of thrombosis. They are really challenging. In another entity that interventional radiologists manage, dialysis fistula formation for kidney failure and dialysis can also become be a hypoplastic vein that doesn't develop into a size that allows the kinds of flow that we need to do the dialysis. There is a technique that is used to treat that vein called maturation procedure, and the physicians of American Access have been very instrumental in developing that technique. I've asked Kevin to come back and talk about maturation procedures to see perhaps if there's some opportunities that we could use to bring over that technique into the CCSVI treatment of hypoplasias. So the next talk will be on maturation of hypoplastic veins. Thank
you. Well, Sal asked me to talk about this. I have quite a bit of experience treating patients with end-stage renal disease and fistulas, and a question arose whether the kind of techniques that we used in dialysis fistulas could work in patients with hypoplastic veins and CCSVI. So let's get started here. A little bit of a departure from CCSVI for a bit. This is the problem. Hypoplastic jugular veins. Some of them are even much narrower than this. I'm sure people with more experience than me can show me even more, show you even more extreme cases where you have jugulars that are just a few millimeters. So how do you approach this? If you dilate it aggressively, it's likely to thrombose. So let's kind of take a different tack here for a little bit. We see a fair number of fistulas that don't mature, and that's one of the problems with end-stage renal disease. Fistulas work great, but when they don't mature, it's a real problem. And here's a patient that I saw back in the 09. Here's the elbow, shoulders up here. This is the cephalic vein. It's anastomosed to the brachial artery down here. You have this short segment that's very pulsatile, high pressure, and no outflow. And what's happened here, here's the cephalic vein, and it's simply occluded. I could not get through that, so what to do? I was able to get a guide wire through, and what you're going to see here is a series of gradual dilatations to bring the patient back. You gradually dilate, and often you have a vein that's a millimeter or two. I'm sure when we angioplasty, we're doing a lot of disruption, but here's now June of 09. Bring the patient back a little bit later, redilate up, get a larger lumen. And this is in August of 09. This is a little longer than usual. Usually I could do this in about 6 weeks, about 2 or 3 weeks apart. This, frankly, was a patient who had a very low pain threshold. This hurts, and he was not happy. Didn't want to come back. His nephrologist said, you have to go back or get a new fistula. And of those choices, he decided to, every now and then he would come back to me. We gradually got him up to the point where we had a functional fistula. And this worked very well. He came back. Now, this is in 2011. Came back. I had to use a stent in one segment here. He had an in-stent restenosis, but great big dilated fistula, high flow, perfectly functional fistula, working well. I'll show you another example here. Fistula, I believe we're in the forearm here. This is a cephalic vein. You can see there's no outflow. This actually is not continuous. It's a branch here. So there's all sorts of collaterals going off here, and I can go back here, show you what I did. I dilated up this stenosis here. Here's the cephalic vein here, stenosis. I first dilated that up just to kind of see, and I brought the patient back a few weeks later just to see what would fill. And I saw this little tiny vessel here, and I decided to try to put a guide wire through it. I could not find the cephalic vein, but this is just some little unnamed vessel, and you're going to see what I'm going to do is hook this up to the axillary venous system, or rather, I'm sorry, the basilic venous system. So I got a wire through, dilated it up. The first time I took it up to 4 millimeters, so I took something that was probably a millimeter, took it up to 4. And again, we brought the patient back. Sequentially got this up to, probably 7 or 8 millimeters, a good high flow fistula. There is a stent in here, and you'll see that, I'll show you that again later. There was restenosis in there. But you can see we took this and ended up with this. This is the hand, this is the shoulder. Basilic vein, so very nice results. So we took something that was, again, probably a millimeter or two. At this point, it's probably up to about 8 millimeters. And the interesting thing about this is you bring the patient back every few weeks. It gets a little bit bigger on its own. You dilate it further until you get it big enough that it can be used as a fistula. And then this is now out, I think this is out about 1.5 years or so to 2 years. And this is a stent that I used. He did have to come back occasionally for angioplasty of that, but again, a high flow, perfectly functional fistula. Just another example, cephalic vein, upper arm. This is my guide wire, it's occlusive. There's a very high grade stenosis here. The whole cephalic vein up above that stenosis is very small. You see very, millimeter or 2 cephalic vein. Gets a little bit bigger up where it joins the subclavian vein. The first angioplasty, we got up to 5 millimeters. Brought the patient back 6 weeks later. There's some areas of narrowing. We angioplasty those. And ultimately ended up with a fistula that looked like this. So we took the vein from this to this within probably about 2 months or so. Another example here, this is down the forearm. The cephalic vein, you can't see it, should run up here. There's a little tiny short segment down near this woman's wrist, which is pulsatile. Everything's going out through collaterals. Not so much unlike some of the CCSVI patients that we see. Oops, let me skip there. I gave a little nitro. I got a little bit of dilatation of cephalic vein. I was able to get a guide wire up this. Here you have an 018 guide wire up. This is my sheath down here. Injected, you see up above. This is the upper forearm here, elbows up here. A little bit of, again, a small vein, really nothing down here. And I'll just sequentially dilate this. Same pattern, we sequentially dilated it up. One point I want to make here, though, is that this is the cephalic vein, this is the basilic vein. The basilic vein the communication here is via collaterals. I angioplasty, stented up this cephalic vein, left these open, which to some degree kind of breaks the rules. You're supposed to have just one outflow, or one outflow if you want cephalic vein. And what happened here is this thrombosed. And again, this may be relevant, and I'll come back to that with the CCSVI patients. If you have another alternate pathway, even though it's by collaterals, often the area that you angioplasty and stent extensively will thrombose. Again, I'm just going to show you that. Here's the cephalic vein that's occluded, which I stented in angioplasty. Here are these collaterals through the basilic vein. Skip over here. So this is now a few weeks later. You can see that little vein that was very tiny has now been dilated up. 2 weeks later, much larger now. But the cephalic vein that I opened up and stented thrombosed. However, there's outflow via the basilic vein. This is at 4 weeks. A little bit of thrombus in the cephalic vein there. I actually did a suction thrombectomy. It looked a little bit irregular here. I was kind of concerned about it, so I got the patient back at 5 weeks. Looks nice. So this is the fistula now. This is our forearm. This is where they cannulate. It's up probably about 8 millimeters or so. Remember, this before was probably under 1 millimeter down here. Outflow via the basilic vein, the cephalic vein, which I worked so hard to open, has thrombosed, but she still has good outflow via the basilic vein. Again, this is about about a year later or so, a little under a year. Nice big fistula, working well. So kind of the principles are, you identify an outflow vein and a superficial location. You try to get up to 6 millimeters during the first intervention. Not always possible. It is painful. And then we enlarge the vein 2 to 3 millimeters every 3 weeks. And the end point is, if the fistula is very superficial, we want to get up to 8 or 10 millimeters. 6 is sometimes adequate, but this is usually, we want to get up around 8 or 10. If it's deep, it may go up all the way to 16 millimeters. So we do go up quite large on these. Long-term patency, this analysis divided them into 2 classes. Class 1, they were deep, not necessarily small, but they couldn't be accessed because they were deep. Class 2 were superficial, but very small. Didn't really make a difference. These are the patencies. Primary patency, not wonderful. Secondary patencies, reasonable. Here are the secondary patencies for Class 2, the ones that started off small. A year, about 3/4 of the patients were open. Out of 3 years, down to about a third. This is pretty good for fistulas. Is this good for CCSVI? Probably not so wonderful if this is a patency for CCSVI patients. Whether you'd have such a drop-off with CCSVI, I'm not sure. These have high flow. There's a lot of intimal hyperplasia that occurs in these patients. So it may actually, if you can get open and flow, CCSVI might not be as much of a problem. On average, these fistulas require an intervention a year. That's an issue. They do require maintenance. So I guess going to the question of could this work in patients with CCSVI, I think you have to take a step back and really ask, why is this working? I mean, it's kind of remarkable. You can take these little tiny veins and just dilate them to the point where you're probably disrupting probably all 3 layers of the vein wall. So how does this work? Why don't you get extravasation? Why don't you get thrombosis? And I looked to kind of done some research on this, just of the literature, and it's kind of interesting if you look at what happens. Why do fistulas mature? There's some animal models where they've created fistulas in the pelvic veins of rodents, and there's matrix metalloprotease 2 and 9 are secreted, and their inhibitors are downregulated when you create these fistulas. And it seems to be and what these do, they're collagenases. They allow outward dilatation of the wall, and they're associated then with collagen repair in a form of collagen that actually strengthens the wall. And it appears, at least in this animal model, it appears to be flow related rather than pressure. There was not much pressure increase, but marked increase in flow. And their conclusion was they think that all of these changes are probably related to high flow. This is another kind of a similar concept here. These are rat hearts. There's a heart with an overexpression of MMP2. These are 8-month-old animals sacrificed. This is a wild type, normal heart. Those with overexpression of MMP2 dilates, rather dramatic dilatation. No angioplasty here, just from the pressure. In patients, this is a study where they looked to see, whether fistulas mature a lot, and they looked at MMP2 and MMP9 and their inhibitors. They looked at the ratio. They had 20 patients. Maturation was successful in 13 and failed in 7. And the patients who had mature fistulas had significantly higher levels of MMP2 to their inhibitor. The ratio was higher. MMP9 and its ratio to its inhibitor, there was a trend towards significance. So these same processes appear to occur in patients. These were serum levels, but the same thing appears to be going on. The other issue when we do these sorts of angioplasties is thrombus formation. This is a model of how platelets are activated. They probably activate in areas of shear stress. This is an aneurysm model, and then they get deposited in areas where the shear stress levels go down. No doubt when we do these fistula maturations, we're creating areas that have these vortices, and I'm sure we are too when we treat patients with CCSVI. And I'll come back to this point in a second here. Thrombus formation, again, when we do angioplasty, we are no doubt in both these situations exposing the blood flow to tissue factor, which leads to a whole series of cascades that lead to the deposition of fibrin. One of the things that probably happens in these fistulas is that there probably is platelet deposition, but thrombus formation from fibrin is probably somewhat limited by the high flow rates that tend to wash away some of these clotting factors. So going back to the question of would this work in CCSVI, I think one of the issues is flow rates. I think the drug dealers can potentially have very high flow rates, but I think as those of us who treat this know, at the end of our procedure, sometimes we have good flow rates and sometimes not. And I suspect in those patients with poor flow rates, this would not work. You probably would have thrombosis. If you have high enough flow rates, it might work. Other issues, probably we have to aggressively anticoagulate. Another issue is multiple treatment sessions. These usually in fistulas require 3 treatment sessions, 2 or 3 weeks apart. Probably a hard thing to do with CCSVI patients. It would mean they would have, I know my patients often travel from a distance. Traveling is challenging for them. They would have to probably stay locally for a prolonged period of time or come back. That's an issue. Primary assisted patencies that I showed you are probably okay for fistulas. They're actually pretty good numbers for fistulas. But of course, when a fistula fails, you just put a new one in. You can't. This is with CCSVI patients. Obviously, this is a much bigger problem. If a year or 2 out, the vein thrombosis, that's a much bigger problem. So probably you have to follow these patients very closely, and do a lot of interventions to keep these open. But potentially, I think in some patients this could work. I wouldn't recommend that you all go out and do this. I think probably it's the kind of thing we should do on a very limited basis. Maybe people like me who have experience with this sort of give it a try. Potentially it could work. Thanks.